Thank you, everyone. My name is Chiara Robba, and I work in Genova at Policlinico San Martino in Italy. So, mechanical ventilation in brain injured patients. This is not an easy topic at all to discuss because mechanical ventilation in brain injured patients has always been controversial. So I will try at least not to make any confusions in the next 12-15 minutes. I will try to clarify some points, and I will try to tell you where are we now in terms of research and where we are going in the next year. I have no conflict of interest. This is the agenda for the next minutes. And as always, I think that we should start from the pathophysiology. So why is it so different? Why is it so complicated to ventilate brain injured patients? Well, there is a dangerous crosstalk between the brain and the lung, and they are strictly connected to each other. So when there is a patient with a brain injury, there is a release of inflammatory mediators which can cause subsequently acute lung injury. And also the treatment of a brain injury itself, like hypothermia or barbiturates, could have detrimental effect on the lung function. And on the other hand, acute lung injury can cause an inflammatory mediators release which can affect the brain. This is described also in some experimental study. This is a very famous experimental study from Hoyer et al. Or from 2011, who included four group of pigs, control, ARDS pigs, and a model of acute intracranial hypertension, both after control and both after ARDS. And the result of this experimental study are here and are telling us that the development of acute intracranial hypertension can increase the extravascular lung water index, both from the control and in ARDS patients. On the other hand, as we were mentioning, ventilator-induced lung injury can cause and promote brain injury. Again, this is another experimental study. Rats were randomized in high tidal volume and low tidal volume, and here there is a significant difference in the development and increase of the C4 positive cell, which is a marker of neuronal activation. And clinically speaking, this is of extreme importance because the development of peripheral organ dysfunction is associated with worse outcome in brain injured patients, especially respiratory complications. Fortunately, they are not that common. We recently performed a retrospective large study with more than 800 patients after subarachnoidal hemorrhage, and we found that the occurrence of ARDS after 1 week is around 3.6%. So it's not that common nowadays. However, when it occurs, it is independently associated with poor outcome at ICU. Now, which is the state of the art regarding ventilation strategies in the general ICU population? This is the very famous PREVENT trial published 2 years ago on JAMA, where the patients were randomized in tidal volume of 6 versus 9, so low versus intermediate tidal volume, with primary endpoint were ventilator-free days and mechanical ventilator days here. So the results from this trial are telling us there are no differences in terms of primary or secondary endpoints, so no differences in ventilator-free days or mechanical ventilation days, but the group with low tidal volume had a higher frequency in hypercapnia, which resulted in a higher frequency of delirium, which could be extremely detrimental and of concern in patients with brain injury where hypercapnia can also cause increased intracranial pressure. Let's clear our results regarding the optimal PEEP levels in the general population in patients without ARDS. This is a nice systematic review and meta-analysis from Ari Serpaneto and colleagues, and randomized control trial comparing low PEEP versus high PEEP. As you can see, the results show high heterogeneity and low quality of the study, so this probably needs further research. However, results from this meta-analysis suggest that a high PEEP has no effect on the duration of mechanical ventilation, but probably is associated with a lower rate of ARDS. So very low levels of PEEP should be avoided. For sure, what we know in both ARDS and non-ARDS patients is that plateau pressure is associated with hospital mortality, and in fact, in the both population, an increase of a plateau pressure is strongly associated with adjusted probability of in-hospital mortality. So in general population, be protective, low or intermediate tidal volume, controlling the CO2 for the delirium and for other complications, and an appropriate level of PEEP. But the question is, why is it so different to apply these principles in brain-injured patients? Well, there are some specific concerns in this group of patients because there are concerns regarding the use of protective ventilation strategies and in the use of rescue therapies. For example, the use of low tidal volume, which can cause permissive hypercapnia, can further increase the intracranial pressure consequent to cerebral vasodilation. And this, in neurointensive care, we know that should be avoided. At the same time, the use of rescue therapies or the IPEEP or recruitment maneuvers, etc., could increase the intrathoracic pressure, which again can have a detrimental effect on intracranial pressure. And the result of this concern is that there are some false beliefs in neurointensive care regarding the mechanical ventilation, and traditionally these patients were ventilated with ZIP, so with no PEEP to avoid increased intracranial pressure, were ventilated using high tidal volumes, were avoided in these patients prone position, recruitment maneuver, etc. ECMO was considered sort of very dangerous because of the risk of bleeding, and there are a lot of concerns in the application of the strategies used in the general population in brain injury population, especially when there is a concomitance of acute brain injury and ARDS, because in these two situations, the ventilator targets such as the PaO2, the CO2 are slightly different, and the use of the rescue therapies and the therapies to apply to help the lung can have detrimental effect on the brain and vice versa. So giving a final recommendation is not evidence-based, could be a bit down. We suggest, for example, to keep a PaO2 around 75-80 to use protective ventilation, to aim to normocapnia, to avoid hypercapnia, despite the use of low tidal volume, but for sure, more research is absolutely needed to clarify these points. However, things have changed a bit over the last years. This is a nice paper which describes how the ventilator strategies have changed over the last 15 years. And as you can see, 15 years ago, there was a significant number of patients who were ventilated with tidal volumes higher than 10 milliliter per kilo of predicted body weight, and this number has importantly reduced now. And in fact, at the same time, 15 years ago, there was a significant number of patients who were ventilated with less than 5 centimeters of water of PEEP. And now the median values of PEEP is importantly increasing over time. We recently conducted, thanks to ISICEM, a survey, the Ventilo survey, regarding the ventilatory strategies in patients with severe traumatic brain injury, and the respondents from all over the world suggested that they are not scared to use low or intermediate tidal volumes in patients with brain injury, and that the use of PEEP is not a huge concern, both in patients who have intracranial hypertension and in patients who do not have intracranial hypertension. So especially the PEEP should be applied according to the need of the lung. Also, results from this survey have also suggested that even some rescue maneuvers could be considered in brain-injured patients, for example, the use of prone position, bronchoscopies, or recruitment maneuvers, and in some cases, also the use of venous ECMO in refractory respiratory failure. What is the situation in the operating room? Basically, we did a post-hoc analysis of the Las Vegas studies. We've included the brain-injured patients, and what we found is that, again, the median tidal volume used in the intraoperative settings in neurosurgical intervention is around 8, with levels of PEEP which are never below 4 centimeters of water, and still a lot of attention is paid to the plateau pressure and to the peak pressure, and generally with this tidal volume patients are able to be ventilated in a protective way with low plateau pressures and peak pressures. And if we have a look at the ventilatory settings that are applied in the operating room in non-brain injured in patients in red and in brain injured patients in blue, we can see that the PEEP, the driving pressure, the peak pressure, and the respiratory rate are not significantly different among the two groups, thus suggesting that when the lung is healthy, probably a lung protective strategy with intermediate tidal volume here are probably the best choice. Now, where are we now and when we are going in terms of research? We asked to a panel of 29 experts in neurointensive care and respiratory failure, and we performed a consensus on mechanical ventilation in brain injured patients. We divided the experts in 7 groups, and for each group we performed a meta-analysis with a systematic review, with a grading, and then formulation of the statement. We are now finalizing the manuscript and the definition of the statements, which was performed using the Delphi approach, but I want to show you some major results from this consensus. So the first one is that we found a very good, a strong consensus regarding the use of lung protective ventilation strategies, even in brain injured patients. Nearly all the experts agreed when there is not ICP elevation. When there is ICP elevation, we did not find a consensus, but lung protective strategies should be still considered. And looking at the feedback obtained from the expert, what we found is that basically all the experts agree that lung protective strategy should be maintained, but with a strict neuromonitoring and avoiding intracranial hypertension increase and controlling a bit the CO2 and treating the tidal volume and the respiratory rate. Regarding the PEEP, nearly all the experts agree that ZIP should not be used and that the level of PEEP to be set in brain injured patients should be the one that normally we should use in patients with no brain injury. And finally, regarding the rescue therapies, we found a consensus regarding the potential utility of prone position in patients with brain injured patients. However, still concern and still confusion remains regarding recruitment maneuvers and the use of ECMO for the risk and the concern of instability of intracranial pressure or for the risk of bleeding in cases of especially traumatic brain injury. So, in conclusions, the concept of lung protecting ventilation is gaining popularity even in the group of brain injured patients. There are some false beliefs which have been a bit clarified, and the answer is that probably that we should apply lung protective strategies paying attention to the brain need. And this results in the need of a very strict neuromonitoring. Sometimes, in most cases, mechanical ventilation in brain injury patients should not be so different from this one on the general population, but please pay attention to the ICP because increase of ICP are associated with worse outcome. There are still a lot of questions which remain open and unanswered, and to do so, to answer some of these questions, we have prepared a multi-center observational studies, which is regarding the practice of ventilation in brain injured patients, which is VentiBrain. The study is about to start. We have already something like 150 centers which would like to join us. And these are basically the objectives. So to assess the ventilator safety in mechanical ventilator patients, and to assess the association with outcome in patients with and without intracranial hypertension. These are our contents. Please join us, and in the meantime, I thank you for your attention.